Good evening, everyone. My name is Bob Christensen. I'm the moderator for tonight's CMT webinar entitled CMT and Breathing. There's close to 500 registrants tonight, which is really a record for us. So I think we have a topic here that many are very interested in. Tonight, we are joined by Dr. Ashraf Elsayegh, a pulmonologist with Cedars-Sinai Medical Center in Los Angeles. Dr. Elsayegh is also a CMTA Advisory Board member. Dr. Elsayegh will be talking about how CMT can affect breathing and potentially cause sleep apnea, which exercises may help maintain respiration strength, and what to do if you're experiencing any breathing issues. So, with that introduction, good evening, Dr. Elsayegh. Thank you for joining us. We do see your screen good, so with that, I'll let you take it away.
Great, thank you so much, Bob. Thank you, everyone, for joining us. I'm very honored that many people are listening in. I know that it's almost 9 p.m. On the East Coast, so we'll try and keep this within a reasonable amount of time, so it's not too late for everyone on the East Coast. All right, as Bob mentioned, I am a pulmonologist at Cedars-Sinai. I'm also an assistant professor at UCLA, and I've been practicing pulmonary medicine for almost 16 years now, and specifically with neuromuscular patients for close to 15 years as well. So hopefully I can help answer some of your questions tonight. I want to remind everyone that I am a pulmonologist, so I don't want to get too much into the neuromuscular aspect of CMT, but I'm just a brief 1 or 2 slides about what CMT is. As everyone knows, it is a spectrum of disorders. It affects the peripheral nerves that carry motor and sensory information to and from the brain. This results in development of weakness as well as sensory problems in both the lower and upper extremities. In general, the symptoms predominantly are in the lower extremities at first, and then they can move up to the upper extremities. However, any neuromuscular disease, including CMT, that affects nerves which make muscles weaker can affect any nerves in the body. This is where I come in, and this is where the pulmonary problems come in. As it affects the nerves in the lower extremities and the upper extremities, it can also affect the nerves that are used for breathing. So these are the nerves that affect the intercostal muscles, which are the muscles in between the ribs, the muscles in your neck, and the most important ones, the phrenic nerves. The phrenic nerves are the nerves that run down to your diaphragms, controlling diaphragm function. Again, as mentioned before, this causes peripheral nerve dysfunction, which can result in difficulty breathing. I would like to point out, and I always point this out whenever I'm giving a talk to CMT patients in the CMT community, is that breathing problems are usually not a very common hallmark of CMT. However, it can occur, and it's funny because I've given talks multiple times, I've written multiple papers, and ever since I've done this, it seems like I've tripled the number of patients that have come to me complaining of respiratory problems with CMT. So maybe it's a little bit more common than I think, but in general, it's not a very common hallmark of it. What are some of the problems? Well, there are 3 main problems in my field in CMT. Number 1 is diaphragm dysfunction. As mentioned before, the phrenic nerves control the diaphragm, which result in weakness. Now, in general, breathing is affected by multiple muscles. Number 1 is the muscles in your neck, the muscles between your ribs, and the diaphragm muscles at the bottom of your chest cavity. All of them play a role, but we believe that the most important muscles and the ones that play the biggest role are your diaphragm. So the majority of the talk is going to concentrate on diaphragm dysfunction. Number 2 is you can have vocal cord paralysis, and this can affect problems with breathing. It can also affect problems with coughing. Finally, many patients with neuromuscular disease develop sleep apnea. We're going to talk in more detail about what kind of sleep apnea, why this occurs, and how to treat it. So as with any other neuromuscular disease, this can also occur in CMT. This slide is a representation of the pulmonary anatomy. Specifically, unfortunately, I cannot point to the screen, but specifically the phrenic nerves running on the right and left, going down to the diaphragm, which is a muscle, and controlling the contraction of that muscle. As mentioned, we believe that multiple muscles are involved in breathing, but the diaphragm is probably the most important. The caveat to this is, again, we're going to talk about it later, many patients with CMT have scoliosis, which changes the anatomy of the chest wall and of the ribs, causing also breathing problems. So yes, the diaphragm does play a role, but also the anatomy of the rib cage and the anatomy of the chest cavity also plays a role in shortness of breath in CMT patients. And as mentioned on the slide prior to this, the phrenic nerves run on either side of the chest down to the diaphragm, controlling diaphragm contractions. If the diaphragm cannot function properly or cannot contract properly, this is when shortness of breath occurs. Now, many questions and a lot of patients ask, what are early signs of diaphragm weakness? This is a very difficult question to answer because it varies in a lot of patients. However, in general, a very early sign of diaphragm weakness is shortness of breath when laying flat. This is why a lot of patients with neuromuscular disease would prefer to sleep at an angle or sometimes on their side. The reason or the symptomatology when patients come to me, they don't always say that they're short of breath. So it's very important to understand that it's sometimes difficult to ascertain why they're having problems laying flat. I will have a lot of patients come and say, I sleep on 3 or 4 pillows because it's more comfortable. I don't have any shortness of breath, but it's more comfortable. In reality, it's probably because of diaphragm weakness. So that's one of the earlier signs of diaphragm dysfunction. How do we test for this? One of the questions, again, always asked is, do patients with CMT need formal pulmonary function testing, and do they need frequent pulmonary function testing? The answer to this is no. In general, what I like to do is obtain one set of pulmonary function testing on any of my neuromuscular patients so that I have a baseline. After that, we follow the patients with spirometry, which I'll explain in a second. It's a much simpler, quicker test that could be done in any office. So the first thing that we do is we test the pulmonary function. We test for what's called a forced vital capacity and a negative inspiratory force, which again I will mention in a second. And this gives me an idea of problems with breathing muscles. The forced vital capacity is a test that tests for the total volume of air that one can breathe out. The negative inspiratory force measures the force with which one can take a deep breath in. Many times over many years, there's been debate about is the forced vital capacity or the negative inspiratory force better at measuring respiratory muscle strength. The conclusion is we really do not know which is better. And personally, I like to use both, which gives me a more accurate gauge of respiratory dysfunction. So the breathing test, the pulmonary function test, and the spirometry is the easiest test that we can do. This gives us an idea of if there's progression in weakness. It gives us an idea if there is any respiratory muscle problems at all. There are, however, other tests which we can do that can tell us about diaphragm weakness. Number one is what's called a sniff test. A sniff test is basically under fluoroscopic imaging, as if you're getting a chest x-ray, and we ask you to sniff, and we should see the diaphragm move up and down. We don't generally do this unless we feel that the diaphragm is completely paralyzed, or under certain conditions, which again I'm going to mention later, such as having to place a diaphragm pacemaker. Next, and this is a much more invasive procedure, is we can always do phrenic nerve conduction and or diaphragm EMGs. Phrenic nerve conduction is the same as the EMGs that you get on any other muscle, where we shock the neck and we look for diaphragm movement. Now, this is usually painful, but it's the less invasive of the two procedures. The other procedure is diaphragm EMG, which again, we shock the neck, but this time we put needles where we believe the diaphragm is into the actual diaphragm. Again, this is a slightly more accurate way of measuring diaphragm function, but it does carry a small risk when you're sticking a needle into someone's body, obviously. And again, I'm sorry, I can't have, I can't tell if I'm going too fast or too slow, but I'm trying to get through all the slides. And if anyone has any questions about a specific slide, please let Bob know and I can stop or slow down. The management of diaphragm dysfunction. This is a question that I get over and over. CPAP therapy. Is CPAP therapy proper for patients with neuromuscular disease? In general, the answer is no. There is a caveat, especially with CMT, which I'm going to talk about in a second. However, in general, the answer is no. I prefer either BiPAP therapy or non-invasive ventilators, and there's a couple that are out right now. One is a Trilogy, the other one is an Astral, but these are more sophisticated devices in helping with shortness of breath in neuromuscular patients. The reason, number one, is CPAP therapy is a continuous positive airway pressure. What that means is whether you're breathing in or you're breathing out, we set a pressure and that does not change. So you have to breathe. When you're breathing in, you'll get a certain amount of pressure, which will help inflate your lungs. However, when you're breathing out, you have to fight against that same pressure. Patients with neuromuscular disease and respiratory muscle weakness have a very difficult time breathing out against that pressure. It makes it uncomfortable. It makes it more difficult for them to breathe. And that's why I recommend something as a BiPAP, which stands for bilevel positive airway pressure, where you set a pressure when they're breathing in and then a lower pressure when they're breathing out, making it more comfortable. The most comfortable device, however, are the non-invasive ventilators, which I mentioned previously. These are superior and the most comfortable. They help maintain a proper carbon dioxide level in the patients, and we are able to control many more parameters, making it as comfortable as possible for the patient to use. My recommendation is always to wear it at night, and then only as needed during the day. And part of the reason that I say this is, as we'll talk about later, many patients with neuromuscular disease have sleep apnea. The sleep apnea is also treated with these non-invasive ventilators. So we're killing two birds with one stone by having you wear it at night. These are some of the devices that are out there right now. This is a BiPAP, an Astral, and this is the Trilogy 100 device. The masks that are worn, there are many. These are only a sample of some. And every single time I prepare a lecture and I put this slide in, if I ask my DME companies or I Google face masks for these devices, it seems like they're inventing new ones almost monthly that are more and more comfortable. So these are just some of the masks. However, there are some that are much less intrusive and much less invasive and are perfect for patients with claustrophobia or with patients that just don't like masks on their face when they're sleeping. So one of the things that I want to point out, and I alluded to this earlier, is in CMT, as with other neuromuscular disorders, the problem is weak respiratory muscles. The actual lungs are usually not affected. Therefore, the problem is not oxygenation. The problem is usually carbon dioxide buildup, meaning that supplemental oxygen is rarely needed. A lot of times when patients with neuromuscular disease see a pulmonologists or other physicians that are not well versed in these diseases, and they complain of shortness of breath, one of the first things that they do is give them oxygen to use at home. This almost never helps the patient. So again, my recommendation is always non-invasive ventilation. And then the next step is if a patient is using non-invasive ventilation for 24 hours and is now still short of breath despite using this device, then a tracheostomy may be needed next. Again, I want to point out this is unbelievably rare in CMT patients, but it can occur, so I just wanted to at least put one slide in there about it. Basically, if a patient is no longer tolerating or the non-invasive ventilator is not working sufficiently for them, we do a tracheostomy, which is a small hole in the lung. A small hole in the neck, in the throat, with a little plastic cannula where we connect the non-invasive ventilator. We change it into an invasive mode, and we connect it to the tracheostomy. This will help the patient breathe, and it'll essentially breathe for them. Again, I really like to point out that this is unbelievably rare in CMT patients. That is the hallmark and the mainstay of therapy in patients with neuromuscular disease and breathing problems. However, many patients, and I get emails about this, I get phone calls about this, are always asking about diaphragm pacing when it comes to CMT patients and when it comes to neuromuscular patients in general. I have done quite a bit of diaphragm pacing, both in neuromuscular patients and in non-neuromuscular patients. So I have quite a bit of experience with diaphragm pacing. In general, it's very important to understand that diaphragm pacing has equivocal results at best in neuromuscular patients, and it has really never been tested in CMT patients. Does it mean that it would not work? The answer is I really don't know, and it's I take it on an individual basis, and I would highly recommend that if someone is interested, they talk to a pulmonologist that has experience with both diaphragm pacing as well as with neuromuscular disease. So again, because many patients are interested in diaphragm pacing, I will just talk about it for one or two slides. And then we'll move past it because, again, it's not very commonly used in CMT patients. This is a diaphragm pace. I'm sorry. Go ahead, Bob.
Yeah, if we could just pause for a moment. I had a question for the committee. I think it went back one slide or so, but somebody's wondering if oxygen supplementation can make CO2 buildup even worse. And,
that is an. Go ahead. I apologize.
No, that's it.
So that is an excellent question. Yes, in some patients, too much oxygen can build up your carbon dioxide even more, making it worse. So that's why I do not recommend oxygen unless you absolutely need it. Now, one thing you have to remember, and I will talk about this at a later slide, is patients with CMT or any other neuromuscular disease can have other medical problems just like any other patient without a neuromuscular disease, meaning that if they have problems with their lungs, which is, again, not the hallmark of neuromuscular patients. Neuromuscular patients have problems with the breathing muscles. But if you have problems with the actual lungs, such as emphysema, if you're a smoker and you have emphysema, you can always have asthma, you can always have restrictive lung disease. These are all diseases that are problems with the lung. In some of these patients, oxygen may help because they're needed. But in general, if a patient just has neuromuscular disease and breathing muscle problems, the problem is a buildup of carbon dioxide, and the proper treatment is non-invasive ventilation. And yes, the question is correct that in some patients, giving them oxygen when they do not need it can worsen the CO2 buildup. And that is a second reason I do not recommend oxygen if not needed in neuromuscular patients.
Okay, and we have another question similar to well, not similar, but along that line is talking about the devices. Can these devices not only be worn at night, but can they be worn all day or during the day?
Yes. So I believe I may mention this later in a later slide, but basically, as I mentioned, I recommend wearing the device at night because we kill two birds with one stone with it treating sleep apnea, as well as helping rest the respiratory muscles, exercise the respiratory muscles, help the patient take nice deep breaths at night. This gives the patient more energy during the day. It causes them to be, I believe, less short of breath during the day. Overall it has nothing but positive effects for the patient during the day. However, if a patient is short of breath during the day as well, despite wearing it at night, then what I always recommend is to wear it during the day as needed. Meaning that if someone goes for a walk, comes back, and is short of breath, and they sit and rest, and it takes 30 minutes or an hour for them to recover, I would put the non-invasive ventilator on at that time. It will help them recover quicker. Also, if a patient continues to be short of breath regardless during the day, you are able to use the device 24 hours a day. And that's what I'm talking about. If we reach that point where you're using the device for 24 hours a day and it's no longer working because you're still short of breath, then that's time to start considering a tracheostomy if that's the route you want to go. But yes, you are welcome to use it during the day as well. But I really just say use it during the day if you're short of breath.
Perfect. Thank you.
Okay, so let's move on. So where were we? Okay, so this is a diaphragm pacemaker. It's an external device. It's not like a cardiac pacemaker that is an internal device. So the disadvantage of this is something you have to carry around. The advantage is something that you can plug it in and only when needed, and unplug it when you don't need it or don't want to use it. The procedure is, it's a complex procedure, but done, with experience, it becomes a pretty simple procedure. We make 3 small incisions, and it's done laparoscopically through the abdominal cavity, where we look up at the diaphragm, and we implant the wires that will be connected to the diaphragm pacemaker. So the wires are the electrodes that will be connected, and we connect them from the bottom side of the diaphragm. The wires will come out of the body, and they look like a computer flash drive that's basically taped to your body. And then you connect the diaphragm pacemaker as needed externally. This is what the wires look like. And again, this is someone who has connected the wires, the device to the wires. So that's issue 1, is the shortness of breath. Issue 2 is coughing. Many patients with diaphragm weakness can develop a weakened cough. I mentioned earlier that vocal cords play a role in coughing, but also the diaphragm can play a role in coughing. So what is the big deal if you have a weaker cough? Well, what happens is, without us realizing, whenever we clear our throat or whenever we take a small cough, what this is doing is helping clear the secretions in our lungs. When your ability to cough is compromised, then your ability to clear your secretions is decreased. What ends up happening is you have a buildup of secretions throughout your lungs, which can cause the air spaces or air sacs in your lungs to collapse. This can contribute to worsening shortness of breath, but can also contribute to congestion and overall heaviness in your chest. It's as if someone has a bad cold all the time. So as of right now, there are no real good measures that we have in order to test how strong someone's cough is. There are some devices out there, but they're not very reliable, and I tend really to monitor the coughing clinically more than I do with any devices. When a patient has a weak cough and they complain of a weak cough, and I ask them to cough, if it is a diminished cough, which does not sound like they can clear their secretions, then I intervene and we give them devices. And there are 2 main devices that we have to help patients clear their secretions. The first is what's known as a high-frequency chest wall oscillator, which helps move secretions throughout the lungs. and this helps bring up the secretions. What this does is it helps break down the secretions in the patient's chest, but the patient will still have to expectorate the secretions on their own. This is what is known as a vest device. This is a device that patients wear, wraps around their chest, and it percusses their chest, which helps move the secretions up. The other device is what's known as a cough assist. The cough assist actually helps the patient expectorate the secretions. So the vest helps break down the secretions. The patient still has to cough them up and expectorate it themselves. The cough assist actually helps the patients expectorate the secretions. Let me show you. This is what a cough assist looks like. It's a mask that the patient will hold to their face. It builds up some pressure, and then it gives you a very strong negative pressure that forces you to cough the secretions out. When should you use which device, and which device is better? That is also a question of debate. In my opinion, I like to use the vest very early on when the patient still is able to cough, but it's just on the weaker side. However, if the patient completely loses his ability to cough, then I would move on to a cough assist, which helps the patient simulate their natural cough. So that's problem number one with neuromuscular disease and CMT, which is diaphragm dysfunction. Problem number two is vocal cord problems, vocal cord paralysis. Again, the vocal cords, like any other part of the body, are innervated by two nerves, the right and left superior laryngeal nerve and the right and left recurrent laryngeal nerve. These affect the opening and closing of the vocal cords. Vocal cord paralysis is very rare, and basically what vocal cord paralysis is on this slide here on the left-hand side. As you can see, the vocal cords open and close. When they're paralyzed, they cannot close all the way, and they remain open. This causes several problems, which I'll mention in a second. However, it's important to note that the vocal cord paralysis is usually a much more problematic issue in children, and it's rare in adults. It can occur, but it's not very common. It can present as Go ahead, Bob. I'm sorry.
It's okay. We have a question here about vocal cord paralysis. Can that cause problems with clearing your sinuses, blowing your nose and getting stuffy?
No. So the vocal cords are much lower than the sinuses. So it does not contribute in any way to clearing your sinuses. However, as I'm going to mention in the next slide, I believe, or maybe on this slide, with the vocal cords not being able to close all the way, there's a risk of aspirating. Particles of food that are in your throat can go into your lung. This can cause pneumonia. Another risk is your secretions, your saliva can drip into your lungs as opposed to into your esophagus and swallowing them because the vocal cords are sitting there open. Well, the same concept can occur with sinus problems. So if a patient has severe sinusitis and a postnasal drip where the sinuses are dripping in the back of their throat, if the vocal cords are not fully closed, it can drip into the lungs. And this long-term can cause some breathing problems as well and some shortness of breath. But vocal cord paralysis or spasticity have nothing to do with the actual clearing of the sinuses. Okay.
Thank you.
So again, this is vocal cord paralysis is a problem more in children than adults. It can occur as unilateral, one-sided, or bilateral vocal cord involvement. Unilateral vocal cord paralysis rarely presents with symptoms. As mentioned, you can get chronic aspiration of gastric content, which results in pneumonias, but short of that, it's usually not a huge problem. Bilateral vocal cord paralysis is a much bigger problem. This can cause a stridor, and it can cause breathing difficulties. How do you evaluate this? It's a very simple way of looking at the vocal cords. It's what's called the laryngoscopy. Some of you may have already had it, but basically it's a very small tube, and I'll show you a picture. It's a very small tube that we put through the nose, and we look right at the vocal cords, and we ask the patient to speak, we ask the patient to take deep breaths in and out, and we look at the function of the vocal cords. It's usually not an uncomfortable procedure. It's usually pretty painless. We give some local anesthetic through the nose, and that should do it. Now, the picture here has a young boy sitting there unbelievably quiet. I don't think it's that painless of a procedure, but it is relatively painless and done very easily in any doctor's office. So what do you do if you have unilateral vocal cord paralysis? Really, it's aspiration precautions. Just be careful when swallowing. Be very cognizant of development of pneumonia. If you have fevers or shortness of breath acutely, you have to be very cognizant that you may have developed pneumonia from the aspirations. If vocal cord paralysis becomes very problematic, especially if it's bilateral vocal cord paralysis and the patient develops severe hoarseness and difficulty breathing, then a tracheostomy at that point is indicated. But again, this is a rare situation, especially in CMT, and even in CMT, it's more common in children than it is in adults.
So we have a question here about that, and why does the vocal cord paralysis seem to be more problematic in children, have more of an onset in childhood, and does it resolve as it gets into adulthood, or does it continue to get worse?
So it does not. So that's a good question. Honestly, I do not know the answer to why it occurs more in children. I think it's just something that we notice, but I do not know, or at least I do not have the answer on why it occurs more in children. And it's not a matter of resolving. It's a matter of if it's severe in children, they usually will have a tracheostomy done at that point, and then they grow up using the tracheostomy. And if it's unilateral, they usually just live with it without a problem, and it never really gets better. They're just taught to be careful when swallowing. So I'm not sure on the reason it occurs more in children. It just may be that it occurs in childhood and something is done immediately at that point, specifically a tracheostomy. Okay, so those are issues number 1 and issues number 2 with neuromuscular disease and CMT. Issue number 3 are sleeping problems. As with any neuromuscular disease, sleep apnea may occur in CMT patients. There's 2 types of sleep apnea. Type number 1 is obstructive sleep apnea. Type number 2 is central sleep apnea. Type number 1, which is obstructive sleep apnea, is basically sleep apnea secondary to obstruction of the upper airway, meaning due to muscle weakness in the neck, especially when we're sleeping, or a large tongue. This can close down your airway and decrease the amount of oxygen that your brain gets at night. Type number, or the second type, which is central sleep apnea, is caused by problems with receptors in the brain. Therefore, in obstructive sleep apnea, this is the more common type of sleep apnea that everyone is aware of. This usually occurs in more obese patients. It occurs in patients with very large tongues. Central sleep apnea can pretty much occur in anyone, specifically patients with neurologic problems. However, there are other sleep problems that may occur, which include things such as restless leg syndrome and periodic leg movements. Restless leg syndrome is basically discomfort of the legs occurring during periods of inactivity, and that's usually at night. And what happens is the patients will tend to get up, walk around, and this takes away the pain. This resolves the pain. Periodic leg movements are movements while sleeping, whether it's kicking your arms or legs, specifically periodic. It's called periodic limb movements more than periodic leg movements, because you can either jerk your arms or your legs while sleeping, and this causes severe sleep disturbances. The symptoms of sleep apnea in general: poor sleep, frequent nighttime awakenings, daytime fatigue, and waking up with a morning headache. Snoring may or may not occur. Snoring is more common in obstructive sleep apnea and less common in central sleep apnea. And also witnessed apneas, where the patient's partner will come in and tell us, yeah, the patient stops breathing, 4, 5, 6, 7, 8 times every hour while they're sleeping. and that's what a witnessed apnea is. Again, this is usually more common in obstructive sleep apnea than it is in central sleep apnea. How do you diagnose it? Well, most obstructive sleep apnea, central sleep apneas, and periodic limb movements are all diagnosed with an overnight sleep study in a sleep lab. So one of the questions that I've gotten previously is, in a CMT patient, is a screening sleep study indicated? And the answer is no. Only if a patient has signs or symptoms of sleep apnea would we get a sleep study. If the patient does not have any signs or symptoms, overnight sleep study is not warranted. How do you treat this? Again, in general, and this was the caveat that I mentioned earlier, in general, I do not recommend CPAP for neuromuscular patients. As I mentioned, I recommend BiPAP or non-invasive ventilators. However, in a subset of patients, if a patient has, for example, CMT, no breathing problems whatsoever, no muscle weakness, no respiratory muscle weakness at all, and they have a sleep study that tests positive for sleep apnea. In that subset of patients, a CPAP is sufficient and will work just fine and should not cause any problems. However, if any patient has any kind of breathing problems along with the sleep apnea, then I recommend going straight to a non-invasive ventilator and or a BiPAP as opposed to a CPAP. Periodic limb movements are usually treated or usually improve once you treat sleep apnea. In addition, if they are not fully resolved when you treat the sleep apnea, there are medications that can be used. Restless leg syndrome, again, is a diagnosis that's made clinically. It's not something that we can test for in a lab. It's basically the way the patient describes the pain. If that they're sitting or laying down for a long period of time with inactivity of the legs, they get severe pain. And when they stand up and walk around, the pain goes away. That's the hallmark of restless leg syndrome. And this is treated with pharmacological agents. So we have multiple drugs that can treat restless leg syndrome. So
before we finish there, if we could just go back to the sleep apnea real quick.
Sure.
Somebody had a question here. Can central sleep apnea be referred to as obstructive by doctors?
They should not be. No. So when we do a sleep study, that can distinguish for us if it's central or obstructive, and the sleep study will let us know if the sleep apnea is obstructive or central. Now, granted, the treatment is the same. However, if the patient has purely central sleep apnea, those patients should not be on CPAP. They should be on BiPAP. So on a sleep study, it should distinguish between the two. So no, a doctor should not make that mistake.
Okay, thank you.
So finally, in summary, I want to mention number one is respiratory complications are rare in CMT patients. When problems do occur, they are usually slow in onset and slow in progression. However, if they do occur, it is a very good idea to have a plan worked out on what to do. I always recommend seeing a pulmonologist that specializes in neuromuscular patients. Pulmonologists that do not specialize in neuromuscular patients sometimes do not think of the small nuances that CMT or other neuromuscular patients go through. I always recommend that you follow up in a center that specializes in CMT patients. And finally, I recommend that when you do receive equipment for breathing problems, that the DME or the respiratory therapist from the DME company specializes in neuromuscular patients. And there are DME companies out there that do treat more neuromuscular patients than others, giving them a little bit more knowledge in these patients. So again, I want to thank everyone for listening in tonight. I hope this has helped everyone, and I will open it up to questions. So Bob, whenever you like, you can start throwing the questions out at me.
Sure. So we have a bunch that have come in just the past few minutes. What type of specialist should a patient see for vocal cord issues? Should they see a pulmonologist first or go to an ENT?
So with vocal cord paralysis or vocal cord problems, an ENT usually has more experience, but again, it should be an ENT with some kind of neuromuscular experience as well. Those are very rare. I mean, in fact, the ones that we have here, even on our team, do not have much experience with neuromuscular patients. So those ENT doctors with neuromuscular experience are very rare. So I always recommend starting off with a pulmonologist. There are some possible treatments that we can do for vocal cord paralysis, and those will usually be done by an ENT physician. But I think you should always start off with at least a pulmonologist who has experience with neuromuscular patients.
Okay. Next question. Can pain in intercostal muscles be a symptom of diaphragm dysfunction?
No. Diaphragm dysfunction and diaphragm weakness is almost always painless. So you will not feel any pain. Pain in your intercostal muscles, I would probably look at other causes, whether it's injured rib, rib bruising, sore muscle, or any other kind of damage to the rib cage or the muscles around the rib cage. I would like to point out that since it is a very sensitive area, the ribs, the intercostal muscles are a very sensitive area in that any little pain causes shortness of breath. So to answer the question specifically, no, diaphragm dysfunction has no association with intercostal pain, but intercostal pain can definitely lead to shortness of breath, and that should be worked up separately.
Okay. We have quite a few questions coming in here about exercises and what can you do to either slow or delay the onset of any diaphragm weakness, especially if you have CMT? Do you have any recommendations?
So that's always the $1 million question is, can we somehow slow the progression of CMT muscle weakness or any neuromuscular muscle weakness? The answer is really we cannot stop it. Our hope is to delay the progression, and the way I recommend that is earlier use of non-invasive ventilators if needed, and also specifically about respiratory exercises. In my opinion, any exercise, as with CMT patients, the muscle weakness is not so severe. A lot of these patients are able to exercise or go for walks, or even go to the gym. Any exercise where you're taking big, deep breaths, I think is definitely beneficial. There are devices that are sold, such as what's called an expiratory muscle exerciser, or an EMST, which basically the patient uses it multiple times a day, and all you're doing is really taking in a deep breath. It's just making you take in a deep breath, breathing in and out very deeply. There are studies that have been done with these devices. The studies are more done with emphysema patients. There are some studies done with what's called interstitial lung disease or restrictive lung disease, and there's one small study done in ALS patients specifically. Nothing done in CMT patients. However, the conclusion of every single study is that we just don't know if it's helpful. We know that it is not harmful, and we need more studies out there and larger studies. So my recommendation is, since we know it's not harmful, I would recommend doing it if you like. Again, all it's doing for you is making you take a deep breath. Therefore, if you go for walks and take deep breaths, or ride a stationary bike and take deep breaths, or even do yoga and meditation and take deep breaths, those will all do the same thing. The benefit of them is still to be found out. I don't think there's any studies to see if there's benefit from this or not, but the studies have definitely shown that there is no harm to doing those.
Okay, excellent. Regarding coughing, you were talking about coughing earlier and how to help clear the lungs. Are there any coughing techniques outside of what you talked about there that like techniques used in COPD that might be helpful for individual patients without the best?
Yes. So to answer the question, are there coughing techniques that exist? Yes, there are many coughing techniques that exist. Are they beneficial to patients with CMT? Probably not. the coughing techniques that exist are more for post-polio syndrome. And what it is you're pushing down on your abdomen, which is pushing the abdominal content up into your diaphragm, which pushes the diaphragm up and forces the patient to cough. Those are the coughing, that's the main coughing technique. There are other coughing techniques that are taught in pulmonary rehab, and in pulmonary rehab, again, is more for COPD than it is for neuromuscular patients. But again, really not much. If the patient has such a weak cough from neuromuscular disease, specifically CMT or other similar neuromuscular diseases, the best devices are either the vest or the cough assist. Respiratory techniques usually don't benefit these patients too much.
Okay. Is there something like a portable NIV that can be? I know you said you could use one during the day, and that's you recommend it most at night. But is there something you can carry around and walk around with?
Well, the devices that exist are not too heavy. Most of them are small enough and portable enough that you can walk around with them. This only becomes an issue in someone who is using it 24 hours a day. And someone who's using it 24 hours a day, I would recommend most of these companies that sell these devices have a little cart, which looks kind of like those briefcase carts or luggage carts that they can put the device on and wheel it with them. Now, if someone is in a wheelchair, all of these devices have a little connector that can hang on the back of a power wheelchair. However, this really only applies to patients that are using it 24 hours a day, which again is relatively rare in CMT patients. But is there a different portable device? The answer is no. These are as portable as they get.
As far as I have a question here about scoliosis for someone who tends to slouch quite a bit. Would you recommend like a brace to help them stay straight to increase capacity?
So unfortunately, that's an excellent question. So patients with CMT can have scoliosis. The problem is when you have scoliosis and a deformed rib cage, which I mentioned earlier, patients can develop what's called a restrictive lung disease, where it's the hardening of the lung. They're so contorted from the rib cage being contorted that the lungs become stiffened in that position. This causes a different type of breathing problem, which is called restrictive lung disease, and it can also cause significant shortness of breath. Unfortunately, correcting the scoliosis after you develop restrictive lung disease, secondary to the scoliosis, correcting the scoliosis in any way, whether it's a brace or surgical, it'll help the scoliosis, it'll help the patient, but it does not help improve lung function. Whatever restriction exists will stay the same and does not really come back, unfortunately. So braces, surgery will help the patient's spine and rib cage, but it will not help improve the pulmonary function.
Okay. Concerned about sedation, I guess for surgery and whatnot, dental surgery or whatever. Are there any, for someone with CMT and respiratory weakness, higher concern level or?
Yeah, so now we're assuming it's not just someone with CMT. To answer that question, it has to be someone with CMT and respiratory issues. So in those patients that have a weakened respiratory muscles and a weakened diaphragm, yes, giving them sedation will further weaken their muscles temporarily for the procedure. What happens is that what I recommend is that the anesthesiologist should be aware of your underlying problem. And what I always recommend is as these patients are waking up. Now, if this is a general surgery and the patient has to be intubated, which is a tube in their throat, for the surgery, what I always recommend is when they take the tube out to place them on non-invasive ventilation right away, just until they have full function of their muscles again and the anesthetic has completely worn off. So is it a problem in general with CMT? The answer is no. Is it a problem with patients with CMT and significant respiratory dysfunction? It's not a problem, but it's something that the anesthesiologist should be aware of. And my recommendation is when they're coming off of the anesthesia to be placed on non-invasive ventilation temporarily.
Okay. I have a question here about a sleep study that was done 4 years ago. Someone was diagnosed with sleep apnea. Doesn't really mention if their CMT has progressed or whatever, but is 4 years, should they have another study after a certain period of time?
So in general, with anyone with sleep apnea, the sleep apnea can improve in some patients. It can get worse in other patients. Sometimes the pressures on the devices need to be altered or changed. Being on the wrong pressure becomes very uncomfortable for the patient. So my recommendation is if you were diagnosed with sleep apnea and you had a sleep study that revealed sleep apnea and the treatment is a CPAP and or BiPAP device, the only time that I repeat the sleep study is if the patient at one point says, this is no longer working for me, all of my old symptoms have come back, or it's just become uncomfortable. It's not as comfortable as it used to be. Then I would repeat the sleep study in order to see if the pressures need to be changed. But as a routine, do they need, every 4 years or every 5 years sleep studies? No, not if nothing has changed.
Okay. We have another sort of along the same line, somebody who was diagnosed with obstructive sleep apnea, but before they were diagnosed with CMT, they were given a CPAP at that time. Would you recommend them getting a referral to see a pulmonologist with, a neurological background too?
Well, in general, anyone with CMT should see a pulmonologist and or neurologist who has experience with CMT. However, if someone was diagnosed with obstructive sleep apnea, was given a CPAP, and then later on diagnosed with CMT, as I mentioned previously, if they do not have any breathing problems, the CPAP should be more than sufficient and does not need to be changed. But the specific question that you asked is, once they got diagnosed with CMT, should they go see a pulmonologist that has experience with CMT? And the answer to that is always yes. Okay. But not really to change the device, just to be followed by someone with experience with CMT.
Right. You were talking about restless leg syndrome earlier, and someone that has a question.
I did not hear that. I was talking about what?
You were talking about restless leg syndrome earlier.
Restless leg syndrome, yes.
Yeah, and somebody has a question about any pharmaceutical drugs that can be used for that, treatments?
Yes, there are. There's several medications. The most specific one is Requip. That's a very good drug to treat restless leg syndrome. Actually, there's multiple medications out there. The most commonly used is what's called Requip. But you can ask any sleep specialist, and they should have an answer for that.
Okay. And here's a question about vocal cord dysfunction and diaphragm dysfunction. Is it common to have both, or is it rare to see one patient have both?
So it is not common to have both in any neuromuscular disease. I deal with more than just CMT. I deal with ALS as well and other neuromuscular diseases. I have seen it in a good handful of patients with ALS where they have vocal cord spasticity, vocal cord dysfunction, and diaphragm dysfunction. But in CMT, remember that vocal cord dysfunction is rare on its own, and breathing disorders are rare on their own. So the likelihood of having both would be very, very unlikely. Can it happen? Of course, but it's not very common.
Okay. We have a question that came in the email before about a 65-year-old man who had foot surgery. He discovered that he had one functional lung due to paralysis of his diaphragm. I was curious if there's anything that can be done. Is there pacemaker stimulation? Is it non-repairable?
Okay. So that's a very good question. And basically, that is a whole topic in itself, and I'll try to summarize it as much as possible. So Basically, a patient has CMT, and then they found out that they have unilateral or one-sided diaphragm paralysis. So let's go back to diaphragm pacemaker. The diaphragm pacemaker is indicated only if you have bilateral diaphragm weakness and that both diaphragms are still functioning, just not functioning well. Diaphragm pacemakers are not indicated for unilateral or one-sided diaphragm weakness, and they also are not indicated if you have complete paralysis of one or both diaphragms. Okay, so the gentleman in the question basically is saying that he has one-sided diaphragm paralysis. Can this cause shortness of breath? The answer is absolutely yes. Can anything be done about it? And the answer is also yes. So with unilateral diaphragm dysfunction, and again, I want to emphasize that it has to be complete paralysis, not just weakness. With unilateral one-sided diaphragm paralysis, the mainstay of therapy. Now, first of all, you can teach the patient some breathing exercises. You can see if the patient can compensate for it, which a lot of patients can, and they can, with time, overcome the shortness of breath. However, if they do not, then what I would recommend is diaphragm plication. Diaphragm plication is a surgical procedure where we basically take the diaphragm and we suture the diaphragm, again, from the abdominal cavity, from the bottom part of the diaphragm. So that what happens is when the diaphragm is paralyzed, again, I apologize, it's very hard to do this on the phone without actually showing on a slide, but when a diaphragm is paralyzed, it rises up into the chest. So the lung cannot expand the way it should. Some of the diaphragm paralysis are so severe that the diaphragm actually goes up to midway into the chest cavity. And the patients become short of breath because they cannot expand one of their lungs. So what diaphragm plication is we go in from the abdominal cavity and we suture the diaphragm, and then we pull it down to where we want it, where we fully are able to expand the lung, and then we suture it kind of to the chest wall. And this is permanent. So what we do is we pull the diaphragm down. This allows the lung to expand and usually takes away the shortness of breath. However, because it is permanent, we only do this if there's absolutely no function in that diaphragm. We do not do it on a partially working diaphragm because now you're going to completely eliminate the diaphragm from functioning at all. So we only do it if you have complete paralysis of one diaphragm. So now, can you get unilateral complete paralysis from neuromuscular disease? That's not very common. It's more commonly bilateral weakness. So some causes of it could just be a coincidence that they have CMT and then something that caused one side of the diaphragm to be paralyzed. Some of the causes are trauma to the neck, any way of injuring the phrenic nerve, trauma to the neck, an old car accident, old whiplash accident, a neck surgery where because the phrenic nerve is tiny and it's very difficult to see, sometimes that becomes nicked by the doctor during neck surgery, or even during cardiac surgery. If someone had bypass surgery, you can easily nick the diaphragm. And then, you can easily nick the phrenic nerve, which causes then the diaphragm to be paralyzed. What we would do is we would wait at least 6 months to see if there's any improvement in the diaphragm. If not, the recommendation would be diaphragm plication. This is something, especially if you have a neuromuscular disease, I would highly recommend you see someone who has experience with plication as well as with neuromuscular issues, because this is a very tricky, it becomes much trickier in these patients. Because remember, if I do plication on one side, well, the patient still has a neuromuscular disease and can cause weakness on the other diaphragm as well, which will cause more problems in the future. So this is a very difficult, long question, which I can talk about for an hour on its own. But the answer to the question is, can something be done with unilateral diaphragm paralysis? And the answer is yes. Plication is one of the big ones that can be done, but I would highly recommend you do it with a center that's very, very experienced with this surgery.
Okay, thank you. Another question here that came in. I know we're right at 10 o'clock here now, so if you don't mind, we can maybe go another 10 minutes or so.
Sure. I'm more than happy to go as long as we need.
There are so many questions here. I don't think we'll get through them all. Well, we're not going to get through them in 10 minutes. So maybe we can loop back after the presentation and try and figure out how we can get some of this answered.
Yeah. So what I'm going to recommend, Bob, is, I will try and shorten, as much as possible, go through as many questions as possible. But whatever questions are not answered, if you guys can email the CMT Association, they will send me those questions, and I will personally email back and answer to every question so that everyone has their questions answered. I have a slide here with my contact information, which the patients are more than welcome to call my office. I will do my best to be able to, to try and return some of their phone calls and answer the questions that way as well. Probably it's easier and safer if you just emailed the CMT Association with whatever questions we don't answer, and I promise in the next week or so I will answer every single one with a reply, with an email reply. But go ahead with whatever questions we have left.
Okay, and for those of you who have been submitting questions online, thank you very much. You don't have to submit them again. We have a way of capturing all those questions and who submitted them, so we will get them over to Dr. Elsayegh and get your answers to those. Going back to our questions that came in earlier, spasmodic dysphagia, is this at all associated with CMT?
So spasmodic dysphagia is interesting. So there's what's called spasmodic dysphonia, and I'm sorry, I already said I was going to answer the question as quickly as possible, but this is a difficult question. There's spasmodic dysphonia and spasmodic dysphagia. This spasmodic dysphonia is vocal cord spasms. This is a big problem. It can cause the patients to have stridor and severe shortness of breath. The treatment for this is very difficult, but there is hope and there is treatment, and what we can do, and again, you have to see a very experienced physician, where we can inject Botox into the vocal cords. Spasmodic dysphagia is basically severe spasms of the diaphragm. I apologize. Severe spasms of the esophagus, which is the tube that you swallow through. This causes severe difficulty swallowing. Some of the things that can trigger spasmodic dysphagia are specifically cold foods. It can cause shortness of breath. It can cause chest pain. There are medications that exist, and I'm not a GI specialist, so please don't ask me which medications, but there are medications that exist that can help treat or at least help control the spasmodic dysphagia. Can it occur because of CMT? I do not. I mean, I think it can occur in neuromuscular disease, but I don't know if there's a specific association with CMT.
Okay, thank you. This question here too. Sometimes when I have a lot of congestion, if I'm laying in bed at night on my back and I try to swallow, I get caught in a loop of trying to swallow and failing repeatedly. It feels like I'm not able to breathe, so they're getting stuck. Any idea what that could be, or what that's related to CMT at all?
Yes. So significant congestion can occur in patients with neuromuscular disease. As I mentioned earlier, the weaker the cough you have, the more difficult to clear the congestion. And what ends up happening is when you're laying flat, that congestion builds up in your lung, and it kind of irritates your throat, and it becomes difficult to clear it. What I would recommend at that point is there's a couple of, I'm not sure what kind of congestion they're talking about. There's two types of congestion. Number one is sinus congestion, and number two is pulmonary congestion. So sinus congestion, which can cause postnasal drip, causing the patient to cough and irritate it all night. What I would recommend for that is a nasal steroid prior to going to bed. For pulmonary congestion, what I would recommend for that is a mucolytic such as Mucinex, which helps thin out the secretions, and then something such as a cough assist prior to going to sleep. So I would recommend using the cough assist at night to help keep your lungs as clear as possible for when you go to sleep at night.
I think, let's see, we'll move on to, do CMT patients have more instances of scoliosis? And does scoliosis have any effect on CPAP effectiveness?
So, yes and no. So scoliosis, as mentioned previously, can cause restrictive lung disease, interstitial lung disease, the hardening of the lungs. With patients that have restrictive lung disease, CPAP or non-invasive ventilators are very uncomfortable because the best way of explaining it is it's as if it's a very hard balloon and the pressure is trying to force that balloon to expand. It becomes uncomfortable. Most of those patients will not tolerate CPAP, nor will they tolerate BiPAP. At that point, I would recommend non-invasive ventilators where we can control so many parameters that we can make it more comfortable for the patients. So yes, restrictive lung disease makes things a little bit trickier. Patients with scoliosis makes things a little bit trickier, but in those patients, I've seen great results with non-invasive ventilators.
Okay, and I think we'll probably stop with this one. It'll be about 10 minutes after, but we have an 89-year-old patient with CMT1, and at night
89-year-old.
89-year-old. Yeah.
Okay.
And at night their nose becomes completely blocked, but it opens when they get out of bed. Any thoughts on this with relation to this topic?
Well, that sounds more of a sinus issue. And as mentioned earlier, the best thing for that is, you can start off with a nasal steroid. If that does not work, I would see an ENT for sinus correction surgery, or even if it's a deviated septum for septal correction surgery. So this sounds not really CMT related, but more sinus facial issue related, and that's something that an ENT can help with.
Okay. Last one, promise.
Sure.
I've been told, patients have been told they have exercise-induced asthma. Could that be related to CMT or mistaken because of CMT?
No. So this is something that I want to point out is, first of all, remember, patients with CMT can have diseases just like anyone else. They can have cardiac disease, they can have asthma, they can have emphysema. So be very careful, and again, this is why I urge that you see someone with experience with neuromuscular disease. Be very careful in always blaming the neuromuscular disease on the shortness of breath, because I don't want someone to miss a cardiac problem. I don't want someone to miss a heart attack. But at the same time, I don't want someone to miss asthma, and in this case, exercise-induced asthma. Is it associated with CMT? No. However, yes, a patient can have exercise-induced asthma and be diagnosed with CMT. The treatment is going to be different, and there are treatments for exercise-induced asthma, and that's usually a maintenance inhaler that you use prior to exercising, and that usually resolves the problem and fixes it. So, the best answer for that is, are the two associated? The answer is no. But remember, anyone with neuromuscular disease can have any other disease that can cause shortness of breath. So just always be careful not to put all your eggs in one basket and blame it on the neuromuscular disease and miss something dangerous or life-threatening even.
Okay, well, it's 10 after 10 right now here on the East Coast, and after 7 out there. So I think that's enough for one evening. I'd like to say thank you very much. We still have a ton of questions, but everybody will get back to you as quickly as we can with answers.
And again, thank you everyone for listening in tonight, and I hope everyone has a wonderful night.
Good night. Take care, everyone.
Yeah. Thank you.